Thanks so much for inviting me here. I have a lot of friends here, and it's a real honor to be invited to talk here. As far as disclosures, I do or have done work in the past for CareCorps National, and you'll see some of the stuff there. The last time I got paid anything from them was in 2011, but I am paid in data, and I'm going to, hopefully that disclosure actually will lead into some discussion about the value of data, because I actually consider that to be more valuable to me than whatever they would have given me in terms of cash. I'm kind of a big fan of the art of war, just in terms of, you know, a guy from thousands of years ago having some pretty sage advice, and this is one of the passages. You know, we should count before we do things. Take a look at, you know, analyze before you make an action. Sun Tzu knew that thousands of years ago. It's equally true today, although he was talking about it in the field of military battle, and in the case we're going to discuss, it's for other purposes. Kind of briefly, we're just going to go over the changes to the U.S. healthcare landscape, mostly in terms of information and in terms of finance, and also something about big data and analytics, just barely touching the surface of those, some specific examples of how that can be used, and some new challenges and opportunities. So per capita healthcare costs in the U.S., this is a problem. And then you notice this only goes out to 2006. I'm told that it's well over $8,000 per person per year now in the United States. So it's continuing to go up, and all the talk about healthcare that we've heard, it's not had a great impact yet. I don't know what the impact of the Affordable Care Act will be, but I can tell you this is a big problem. And it's going to involve government, it's going to involve private industry. It's going to be difficult to address, but we have no choice, and I'll show you why. This is how we compare to our the next highest nation, which is right here, Norway. We're almost 50% above Norway in terms of cost. The OECD did a study, and they said, well, maybe it's because the U.S. is a wealthier nation, although we're not wealthier than Norway per capita, but nonetheless, they did an analysis where they adjusted for that, and you can see this ESAW over here. That's where they predict we should be down here, and we're up here. So in other words, we're spending too much, even accounting for the fact that we're a wealthy nation. And those are OECD nations. We're not talking about third world nations. So if they're saying we're too rich, then I mean, that we're spending more than we should, then we probably are. This is the percentage growth year over year of healthcare in the United States, and you can see the green represents the growth of healthcare spending, and the red represents the growth of our economy, the gross domestic product. Now, I only took it out to 2006 when I did this, but I used the average of the difference between the two to project the percentage of our GDP that would be taken up by healthcare over time. And you can see that just shortly after the turn of the next century, we're all going to be doctors or nurses, because 100% of our GDP will be healthcare at that rate. And that's just, it's obviously not sustainable, not going to happen. So we have to keep that in mind, that something is going to have to change. And I guess, like I say, all the discussion is political. But at the end of the day, economics almost always trumps politics. I mean, it doesn't matter what politicians want to do or don't want to do. The economics of the situation will drive it. Ask Louis XVI. He had an interesting experience with economics when it didn't work so well. So cost trends, and here's Medicare, and this is the same kind of a graph here. You have gross domestic product down here in terms of the growth until 2008, national healthcare expenditures, and Medicare. Well, the premiums are going up. This is part of the reason the Affordable Care Act was examined and looked at, was we can't keep having premiums, double this fast when in fact the workers' earnings and overall inflation have not matched it. So it's hitting home. What about pathology? I mean, we're immune, aren't we? We're doing okay. Well, this year we had some interesting, shots across the bow. I guess actually they were small hits on the bow. There you go. There was a marked reduction in the 88305s, and I'll show you a graph of that. That's the primary code used in surgical pathology for biopsies. They are limiting the number for prostate needle biopsies, which I thought would happen at some point, because we had some docs that were submitting, I think, up to 16, different prostate needle biopsies in separate containers so they could get the maximum reimbursement possible. The stat coding for molecular diagnostic testing, another thing that's happened, and there's more that's almost certain to come. Here, this took a lot of work, surprisingly, for this graph, but it's so illustrative. This is the 88305, that code in surgical pathology. You can see the change over time. What I want you to notice is the red is the professional component. That's the component they pay for our professional interpretation of that slide. It's actually gone down. Now I want you to notice this is real 1999 US dollars. If you use nominal dollars, it went up slightly. But in other words, you can afford to buy less with the pay you get from your 88305 now than you could back in 1999. The technical component, back in 2001, I knew that it had crossed, and so it appeared as though our friends in Washington at CMS actually valued the technical component more than the medical component, which made me feel bad because I feel like we're doing important work. But of course, the technical people do too, so you can't feel too bad. But you can see that the technical side just got chopped down. Now they're both bad, or not as good. And this is having an impact out in the community and community pathology practices. I interact with quite a few, mostly in the western and the southern United States. A lot of them are very worried about their income, especially if they had a laboratory. This, as I was flying here, grabbed this at the airport yesterday morning. You'll notice the date on here. It's very rare that I present something that's next month. That's, usually my references, I try to keep them within a few years, but this is pretty good. October 2013. Strategy that will fix healthcare. Michael Porter, a famous strategist at Harvard Business School, and Tom Lee, who was at Partners Healthcare. And this is one of the diagrams. I'm probably the first one to make a diagram out of it, but I give attribution, so I'm not stealing it. Notice what they're talking about. Organize into integrated practice units. That sounds like an ACO to me. Measure outcomes for every patient and costs. Bundle, this all sounds like the ACO kind of model. This is, I think, where they want to go, where things are going to go anyway. And then the part I like down here is that they did include the bar, which they kind of included that as a way of saying this encompasses all of these parts. The sixth element, as opposed to the fifth element, which is a different movie. Building an enabling information technology platform. And this is a way of looking at just a back of the napkin calculation of what percentage of the healthcare costs are represented by laboratory. It's about 2 to 3%. And you say, well, okay, we're not very significant, but we are. This is data that I had from Massachusetts, discharge data set. If you look at the direct cost compared to direct cost for inpatient medical diagnoses, we're about 6 to 7%. And that's direct to direct. I'm not looking at total overhead. This is getting the overhead out of the mix. You say, well, okay, 3% to 7%. He's still delusional. We're still not important. We're not above. But the only area of the hospital that actually was bigger in terms of direct costs were the operating rooms. I'm not talking about overhead. That's a whole different animal. So let's talk a little bit about information. I love this paper. This was the paper where the basic unit of information was defined. Believe it or not, the kilogram came first, the meter came first, the bit came a lot later. This was Shannon out of Bell Labs. This is back in the days when Bell Labs was a powerhouse productivity factory. Background radiation from the Big Bang discovered there. So was the bit defined. Well, we're not talking about more than just bits. And I'm told we're kind of living in the zettabyte age. What I really like is somebody's given Carl Sagan some credit. The Sagan byte, that thing's a monstrosity. It's 10 nontillion bits of information. We're just growing faster and faster. And here's an infograph that kind of describes the exact same thing. 8 zettabytes in 2015 per year versus 2.75 last year. So our information is growing. How does that impact us? Okay, it's nice to talk about bits and bytes and, nibbles and all that nonsense, but what about us? Well, PubMed, the source of all knowledge, right? We just crossed the million boundary 2 years ago, 1 million per year. And so a long time ago, they don't play this ad anymore, but there used to be an ad where they could teach you to read 100,000 words per minute, which I coveted because I thought, man, that would be a great skill to have. Except that, he sounded pretty convincing. It was usually on the radio, if I remember right. But I thought, let me calculate how many days. Let's assume that I did it successfully and that I was good at it. It'd still take me 99 working days. So more than a third of my year, I'd come to work and I'd be reading all day long. I don't think my boss would go for it, and then how much would I remember? Second question. Just looking at sensitivity and specificity. So I say, okay, I don't want to read the articles about radiology and all that stuff. I just want sense and spec. That's still growing at 8% per year, compound annual growth rate. Can't keep up with that either. And then, sorry Andy, but it gets worse on this side too. You just can't win anywhere you go. So the GenBank core nucleotide sequences have absolutely exploded. I think that we're getting close to 100 million in total. This is per year. So, and then there was a paper that came out. This was presented at an AACC meeting, and I loved this statistic. They asked physicians, how fast do you want to be able to interpret diagnoses for genetic testing? They basically said 90 seconds. We want to know, for personalized medicine types of stuff, I just want to know what I need to, it wasn't that I want to read it in 90 seconds, I want to know what I do next in 90 seconds. That was a survey that they presented at AACC, so. But big data. The three things about big data that make it different, because size, we talk about size matters, it does in this case, I guess. It's the volume of the data. Huge, they're so much bigger that we can't handle them with traditional relational databases. That's part of the problem. It's the velocity with which the data is transmitted, with which we need to analyze it. If you did a Google search with a purely relational database, you wouldn't get your answer for months. You need to be able to pull it out faster. So there are new techniques to pull that information out. And it's different types of data. We're now putting images into databases. We're putting audio files into databases. We're putting all kinds of things in there that were not traditionally part of that. So this is where we go next. This is a little room above it's on the floor above my office, and when I walk by, I'm thinking, it's just a matter of time. and it's radioactive too. So, but behind that door, I don't know, man. So what is analytics? How does that help us? Well, you're looking for meaningful patterns in data. That's what you're looking for. It includes statistics, computer programming, and operations research. In fact, the organization I joined about 3 years ago to be able to present this kind of material was an operations research group, and they're very nice folks. And as we talk, one thing, if you can take anything as we discuss, those of you who have an interest in this, I would strongly encourage you to think very broadly about your circle of friends or friends-to-be. There are people out there that can be of tremendous help to you that may be outside of the traditional walls of medicine. The analytic continuum starts with reports, and you go all the way to, they call it prescriptive analytics, is kind of the final place up in here. We're not anywhere close to that stuff yet. That's where we can go, and some places are starting to move that way. Now, Google Web Analytics and a lot of that, outside of medicine, other companies have made great strides. Amazon, based up here, great strides. The 8 levels of analytics, and this is from SAS, and they include this sort of evolutionary diagram. The businessman trying to get up out of the, the mud of standard reports and move toward predictive analytics, but we're still basically down in this area, unfortunately, if even there. So you say, well, who cares about this? Well, from a financial point of view, and you're going to notice that some of the stuff I'm presenting has a financial slant to it. And the reason is because I've found that tends to get attention of people I've worked with in hospital administration and payer groups. And so don't be threatened by it, but if you see it, then you'll understand the patterns, and it'll help you to understand how you can use that as a lever. These are 3 widely known analytics companies. And what I want you to notice that they all did fairly well during the economic downturn. And you say, well, Capital One, minus 6.4%. Well, my Bank of America stock, I would have been happy with 6.4% downturn on my, I took a pretty big hit on that baby. Fortunately, I'm not rich enough to own much, so. But still, it's painful from a pride point of view to watch something that you picked go down like that. There's a study done on the ROI, the return on investment for different analytics projects, and it improves production, absolutely. That's sort of Lean Six Sigma. We use analytics for that, but it's mostly just to follow it. But customer relations, business intelligence with predictive technologies, I mean, a lot of the stuff is moving that way, and that's where the money is. So the business world knows it. This is Google, their part of their balance sheet, and their market cap's about $233 billion, and their goodwill and intangible assets are things that don't exist but that have value and that accountants will allow you to list on a balance sheet. And I don't want to get into the reasons why here because that'll really bore you, but that's still a lot of money, you know, $17 billion worth of stuff out there. But I think that the reason people are willing to market cap it so high is the data. There have been people that argue that data should be included as an asset. It is worth, data is what has built Google into what they are, flat out. They know it, they're not stupid. In fact, they've done deals where they didn't get any financial remuneration. They got data. I'm trying to at least haphazardly emulate them and take data instead of money because data becomes money later. So here's, this infographic, it's harder to see, but they estimate there's $300 billion on the table in healthcare analytics. If we do it right, we can either save that much or increase revenues that much, streamline processes to you know, that's sitting there. It's a lot of money, and I tend to believe it's true. There's a plethora of companies that have, you know, SAS is big and SAP is big. There's a lot of smaller ones as well. Well, IBM's big too, sorry. But they're trying to move into this realm, but you really need content knowledge, subject matter expertise. They might need I don't know, they might need somebody in laboratory if they were going to evaluate laboratory tests. Just saying. Drivers of healthcare BI, there's a study. Managing costs right now is the big thing, but they're also looking at improving medical outcomes. They need to be able to define those better. We can help define those. There's a variety of other reasons. This is where I got started sort of on this journey. It was back in 2003, the National Health Service in the UK wanted me to come talk to them about evidence-based medicine. And so I'm showing this for a couple of reasons. One is, even if we go to a single payer system, government system, they're still going to be very interested in this stuff. In fact, they might be more interested in this stuff because apparently they have to go back to Westminster and, you know, argue to the Chancellor of the Exchequer why they're spending so much money on the NHS. I don't know. I mean, I'm not a Brit, but the fact that they would invite a crazy American over there tells you something, right? And compared to University of Colorado, because when you're a laboratory kind of person, you start comparing laboratories. So how many tests do you guys do? You know, your lab looks a little smaller than average and kind of thing. You do it diplomatically, of course. And about 4 times. We were doing about 4 times the testing per capita. That's a gestalt. It might have been 3 times, but it's still a lot more than they do in the UK. You say, well, that's because the British are backwards. Well, I don't know you can say that. Their lifespan, I mean, a lot of the demographic indicators, they're not any worse than we are. They talk funny and drive on the wrong side of the street, but other than that, they're fine. So resource utilization in pathology and lab medicine. This is another paper, came out in 1999 out of York University in Toronto. So, and I lived in Toronto for a while. I never knew Carl von Walraven, but he did good work. Systematic review of the literature looking at unnecessary utilization. So I reanalyzed it and weighted each of his studies in this according to the number of patients included. And so I used the weighted mean here. They did it 2 ways. They said some of these studies had an expert review. So they looked at the inappropriate utilization. They had an expert of 3 people usually, cardiologists, for example, for troponin orders. They would provide all the information up to the time the troponin was ordered, and they'd say, would you order it or not? So it's an expert review. 58% they found were unnecessary. If you weight this, 58% would be unnecessary. Even the simple mean that they concluded in the paper was 47.5%. Still a lot. If you use a rule, so rule-based, we don't need an expert, we just kind of set up an a priori rule. If this rule is broken, then we assume it's unnecessary testing. In that case, these papers, and there you can see each paper is listed as a bar. So there's a lot more papers in this category. It was 18.9%. I feel more comfortable with that. So I'm going to use that in the subsequent slides. We looked at New Mexico. We said, okay, well, what is this, let's assume that Carl van Walraven is right in his systematic review of multiple studies. I think there were 40-something studies in his systematic review. What it means, and we did 2 estimates of the total cost of laboratory testing per year in New Mexico using 2 different methods. You can see they kind of correlated fairly well, about $1/3 billion. New Mexico is a state of 2 million people, so that should give you some idea. It would be higher in Washington, obviously. Took an average of the 2 methods. We multiplied it by the lowest estimate of unnecessary testing. We came out with $61.7 million, which I originally presented to people in New Mexico. And somebody pointed out that if you're an administrator in the lab, which I was, that would mean part of your job too. So I thought, well, that's not good. I don't like that. So we're going to get rid of the fixed costs, and we're just going to assume the fixed costs stay the same. So the administrative burden stays the same, but we can tweak the rest. Well, in that case, and I used the fixed cost to the variable cost ratio that we had at Tricor Laboratories, so it might be a little higher in academia, but anyway, you get the picture. It'd still be $41 million. And you'll see that that caught the attention of some people later. If you extrapolate that out to the United States as a whole, now I know, we're talking trillions and this and that and everything, but still, $7.68 billion is still, that's still something these days, I think. I don't know. And then we never have found the provenance for this fact. I have looked and looked. It's been quoted by, but I tend to believe there's some truth to it. So take this with a big grain of salt. But nonetheless, there are downstream costs. What I'm showing you are just the cost of the testing. There's a whole world of opportunity for somebody to track the downstream costs because they've got to be much bigger. Anyway, 70% is the figure that's quoted. You will find references to support it. I've never found the actual data analysis to generate it. So somebody said it at one point and it became fact. So we looked at hyperthyroidism initially, and we said, TSH should be done initially, and then there should be a reflex test of some sort for the rest of the testing. And I'm simplifying it a bit because I want to be able to get through everything today. So we had tables that we put together in a data mart, and we connected those tables using primary keys. So we can now connect the laboratory to the cost accounting, to the administrative, to the medical specialty lookup, and to many other things. I'm just showing you a very simplified version of it. This is an example of what we wrote. You say, well, it looks boring. Well, the actual writing of it might be, but it's what you get out of it. So this, I don't mind writing it. This is an example of the frequency with which TSH and free T4s are ordered together. This was more than 6,000 providers that were examined. No, 4,000, sorry, still a lot. You can see that what's the right way to do it? Do you order it together? Well, I don't know, 19%, no, sorry, maybe 15% say always order it together. Maybe 19% never order it together. There's a group in there that thinks that about half the time you should, half the time you shouldn't. So this is by individual provider, the frequency with which they ordered the test together. There's no rhyme or reason to it. And I'm showing you that just for a simple logical fallacy argument, which is they can't both be right. You can't say it's always appropriate to order them together and never at the same time. We looked at individual providers. We can actually get down to that level. So provider A spent $3,323 on unnecessary thyroid reagents, or $6,000 per year on the total cost. You say, well, everything we do is leveraged up. So oftentimes we look at small numbers in the lab and we often get ignored because they say, well, radiology, that's $3,000. You guys are 10. What is wrong with you people? Yeah, the problem is we do millions and they do thousands. That's the problem. So ours expands out quickly. We got some data, aggregate data from an institution of similar size, hospital system in an adjacent state, catty corner to New Mexico. Probably figure out which one it is from there. What I want you to notice is the difference in specialty, and especially the endocrinologist. If you lived in state 1, 1/3 of the endocrinologists always order it together, those 2 tests. If you live in state 2, it doubles. So Even being a subject matter expert, an endocrinologist, doesn't guarantee you're going to get the same pattern. And we looked at a large national payer. We said, okay, how much are they spending? We didn't have the granularity of the data we needed. However, we were able to extrapolate using what we found at the hospital systems. And we found that there was about $1.8 to $1.9 million were spent on free T4 and free T3s, unnecessary. A large Northeast regional payer, not one of the ones I'm going to show you later, he had jumped to $5 million per year for those two tests. So this is, and I'm showing these numbers because this is the kind of dollars followed by 7 digits starts to get attention, 8 or 9 even more. The initial studies that we did led this is only 2 of the bills that were introduced. And you say, well, why aren't you doing work in New Mexico being funded by appropriations from the legislature? Because this is right before 2008. That's why. So they didn't make it because of the economic downturn. But there was a great deal of interest. The sponsors, right here, Representative Lujan was the Speaker of the House. You can't get much higher than that. And Senator Smith was the ranking Democrat. And each of these people were ranking Republican or Democrat. So that's another thing, is that apparently, at least in New Mexico, the two parties, they might have argued about everything else, but on this issue, they kind of saw common ground. And I have to be honest with you, initially I didn't understand the reasoning. But I was, as our lobbyist, because our lobbyist told us that this would happen, I didn't believe him. I said, you just do whatever you want to do, but you're a lobbyist, I don't believe you anyway. But apparently, Medicaid is a big problem in a poor state like New Mexico. So they were interested in finding ways to shave money off of the amount of Medicaid that they would need to spend on things that were unnecessary. And of course, Governor Richardson was the governor, and he was behind it too. So apparently not enough to get us over the hump, but that's okay. This is a wordle from a paper we just published. You can tell what we were looking at just from the terms on there. We did 21 unnecessary tests in this case, divided them into groups, and this is sort of the logic we used to start. So for example, any reverse T3 we said is unnecessary. Now you can quibble about the definitions. You can say, well, maybe in this, just follow the rules, because when we get there, even if you do a sensitivity analysis and you say you're off by 10%, not going to matter much. And there's the free T4, the total T4, the free T3, total T3. We did some where we compared it with the ICD-9 codes. Was the 125 dihydroxyvitamin D, was there a renal failure or kidney failure code in there? We can do that. Some of them we looked at patient age. Was a homovanillic acid ordered for somebody over the age of 20, which Mike can appreciate because he's at a children's hospital. And you say, well, yeah, but occasionally there's that rare neuroblast. Okay, well, fine, but, it's rare. So I'm not saying these numbers are perfect, that the analysis is perfect, but, because the numbers we took, the numbers are what were reported out, what we got. But what I'm saying is you can always nitpick it and say, well, you should have really looked for the diagnosis of neuroblast. Okay, fine, true. But we're making some assumptions in here that I think are pretty safe assumptions. The systems we evaluated, we looked at a large hospital system. 4 hospitals, including 1 rural, more than 500 providers. We looked at a regional reference laboratory system, more than 12 hospitals, more than 4,000 providers. And other hospital clients as well. We looked at 4 regional payers, 2 in the Northeast, 1 in the Southeast, 1 in the Western United States, more than 6.5 million covered lives in aggregate. And I'm showing you a lot of this stuff in aggregate because I don't want to identify who's who too much. I'm sure you can figure some of it out. So the cost of the hospital system. Okay. And I divided it into testing groups. I didn't want to list 21 line items. So for thyroid testing, well, the volume of 14,668 per year was unnecessary using the rules that we came up with. The variable costs of that, variable direct costs were 122,000, the variable indirects 47,000. And we got total costs in here too. Now this is typical hospital cost accounting. It's not necessarily the way I would prefer to do it. I'm very good friends with the Director of Financial Decision Support, and we're actually working on a better cost accounting system than the traditional hospital one. But nonetheless, you can see the total costs with the overhead. You can see costs without overhead, and if you looked here, 251,000, 145,000, that's the cost without the overhead, approximately. About $400,000 we're wasting on these tests that are pretty common, ordinary garden variety tests. I included the 88305 equivalents because I gave this originally to a group of surgical pathologists, and I wanted to let them know how much extra work they would have to do to get that same amount of money. So they would need to generate about 11,000, 12,000 88305 codes. It's about 6,000 biopsies because it's about 2 to 2.5 88305s per surgical pathology case. And turns out that's equal to at least a couple of surgical pathologists, or well over one. So it's a lot of money for a little hospital system. Well, for a bigger hospital system, sorry. The reference lab, it's even bigger. It's about 1.9 million in total. But in this case, we did the cost accounting the way I prefer. Variable materials cost plus labor. Then laboratory means with the laboratory fixed cost added in. So it's just the fixed cost attributable to lab. And then we didn't have any overhead. Well, we did for finance and other things, and that goes into the total cost here. Here's the 88305 equivalents. But the variable cost alone is $750,000. In other words, we're spending $750,000 on reagents and controls and calibrators for the unnecessary tests, which translates to about 20,000 88305s, about 10,000 surgicals, more or less. Here's the real big interesting information, the paid out claims. Now, payers don't have the cost, they don't do it the same way. They just kind of say, this is the money. They have what are called allowables, which are, that means that they've agreed to it, and it's usually pretty close to the paid out claims. The paid out claims means money out the door. So if you're one of these 4 payers, this is what left your company and went out the door to the provider or to the hospital, usually the hospital. In this case, the amount was $32 million. $32,191,739 was spent on the unnecessary testing, and we used the same. You say, well, you included all the free T4s in there. No, we used the same percentages from the hospital systems. We took an average and we said, we're assuming that these payers, that the way that the cases are managed would be similar to that in these other 2 geographic locations. We might be off a little, but still multiples of millions of dollars. And one of the biggest is thyroid testing, 12.2 million. So it's a lot of money, and that means there's a lot of opportunity. Because it's easy for me to show you that. The question is, how do you actually get the savings? As Archimedes said, if you have a lever long enough and a place to stand, you can move the world. So we deal with large amounts of data, large amounts of transaction. That means we have lots of leverage as laboratory medicine practitioners. What are some of the new challenges? Well, my brother, he works at software companies, and some of you can't tell me about, so he's probably spying on me right now. It's like, hi, Vince. I don't know if he's doing stuff with the NSA or not, but I hope not. But anyway, he asked me to draw out he said, well, draw out a grand vision of what you would, this is a couple of years ago, so I kind of drew this out as this is what it would kind of look like. We need to get clinical information mixed with operational, mixed with financial, and anyway, he said, well, you got to simplify from there. It's a little too much. So in the meantime, I learned Clarity is the database we use for Epic. And I've gone to training sessions and I've read their manuals, and believe me, they're boring, but that's where you learn. So you say, okay, so he studied Beaker. We were the first hospital system in the galaxy, the first academic hospital system in the galaxy to implement the Beaker module. Not by my choice. But it's nice to be first in something. And I did the data model fundamentals, which is nothing fantastic. It's just basically relational databases. I already knew that anyway. But here's the thing. We looked at the Beaker part. I've also looked at the Willow. That's pharmacy data, because I want to know how it's structured. Why? You're a lab guy, because that's where the power comes from. Health information management. I want to know the ICD-9. I want to know all the coding system. I want to know how it's structured, because every database is different. It's like opening up the hood and seeing where all the parts are. And they publish these companions, is what they call them. Like, I don't know if I'd really want that for a companion, but I don't sleep with this stupid thing, but you know, you do what you can. And then decision support training, they have the ability to write rules as decisions. That hasn't been done yet. I'm learning how to do it. That's going to be the next step. This we presented at one of the non-medical meetings, got a lot of attention from finance, operations, other people. Once again, I would encourage you, there are people out there that are, broaden your horizon, go out. In this case, we have accounting and finance data. We do at our hospital, it's in all scripts. The finance guys know that. We have laboratory clinical, it's all in Epic now, because our entire system is Epic. There's no other legacy systems lingering around for clinical data. And they will tell you if you ever do that, it's all encompassing. Epic now becomes the grand poobah of data. It's not true. There's always other data, like where's the financial data? Oh, well, that's not part of, well, yeah, that is important to have access to. There's other data from a lot of other sources. We've used data from the US Census, because you can connect zip code, LOINC data, Bureau of Labor Statistics, if I want to adjust for inflation. If I'm doing a study and I want to adjust for inflation, I'll need to have that. And we put it through this. This is the key. ETL, extract, transform, and load. These people are paid a fortune. I mean, if I were to go do it over again, I would not be a doctor, I'd be an ETLer, whatever that is. That's what I'd do, seriously. They're the ones that take the data from these multiple sources, they parse it, process it, clean it, they do all kinds of things to it to put it into a single place. And we'd propose putting one version of it into a big data, including all the stuff we didn't want to clean and process so much, the rest into a relational database management system. You can then get your reports, or your level 1 analytics, you know, your bare bones basics. You can do clinical decision support. You can do the stuff that the administrators love, the OLAP cubes. I mean, they don't know that that's what they're using. Those little, you know, they click here and it's pretty cool and it moves around. I don't know what they do with that, but they can do that. But we can also do much more sophisticated analytics with it. Some of the stuff some of the very basic stuff I've showed you, we haven't even begun to scratch the surface. We presented this, a data model, relational database model, and you say, well, that looks pretty dumb. Well, it took a lot of work. It's an entity relationship diagram for different places, and you can see I color-coded it red, you know, if it's coming from clinical, and, you know, orange if it's coming from an external source. I think the blue is the green is the financial, and so forth. Cost accounting, that's another challenge we have. We don't account for costs very well in healthcare. This is a survey done in 2005, so it may be a little dated, but I don't think it's gotten a lot better. This is of CFOs. Remember that. 71% are aware that activity-based cost accounting exists. And I'm like, wow, you guys are finance guys. I mean, you think you would at least be aware that it exists, but it'd be like me coming to you and saying, are you aware that troponin exists? I mean, I don't care if you know anything about it, but have you ever heard the term, you know? So that's why I'm saying sometimes don't assume anything. Use any cost accounting system at all, 52%, that's scary. I mean, electronic one, I'm assuming. And then implemented ABC, only 4.7%, which means they're pretty good for a few. This is the ETL form. There you go, ETL. This is a guy in CPA. He's getting paid almost as much as I am, very close, and he does ETL stuff. And he also has subject matter expertise in financial information. So it's not just, if any of you told me you wanted to be a lab medicine ETLer, I'd say, well, I want a finder's fee. I mean, if I give you advice, I expect a return on my investment, right? So you got to pay me a little percentage of your first year's income, or something like that. But this is the example of the ETL he set up for the financial data. And we're working on the clinical data, getting it into the financial system, because our IT folks are not so keen about putting the financial into the clinical system. I'm cool. I go either way. You know, data governance, big problem. We have to have a way of determining who has access to the data and when, and not just in the terms of day-to-day work, but research committees, and this needs to be in a way that it encourages research, but also that protects, patient privacy. Data provenance. Where did the data come from? You'd be amazed how many times you go to meetings and you present your data and people will say, well, where did you get that? And this is really important in meetings with hospital administrators. And if you need to know where your data came from, the provenance of the data. Just as important as knowing whether this painting is real or not. And then, I love this too, You can always multiply bad data. You can divide it too. And that gets you to the level of trust. Another problem we have is we have these things called blobs. It's a data type. It's called a blob. The blob from the Black Lagoon. So here's an example of a blob. This is in a relational database. It's a surgical pathology report. You say, well, great. We got all the data in there. Why can't they just do something with it? Well, yeah, but it's text, essentially. I mean, you can claim it's not text. It's a blob. Okay, fine. But how do you get pheochromocytoma out of that? Well, there are ways to do it. This is actually really complicated, but it's a challenge and it's an opportunity. So, Forest Rim has a technology product. Wand has a taxonomy product, and you can use that, and you can pull things out and relationalize them. Now I can start asking questions about, what were the metanephrines? I mean, you already know the answer to that question. Let me think of something more esoteric. What was the glucose? I don't know. What was the glucose in the pheochromocytomas? And compared to the neuroblastomas, compared to the ganglioneuromas, or whatever you want to do, it suddenly gives you the ability and the power to analyze that. And you can also parse it out in terms of size, because they usually give you the dimensions in the gross report. So we can now get a volume of tumor, an estimated volume. Another thing, sometimes we have information from outside. This is back in 2006, and I agreed to do it back then. Some folks at McMaster University and the HRQ wanted me to review a systematic review of literature on BNP. And I said, sure, because I was stupid and didn't realize it was how big that thing was going to be. And I thought it's going to be like a 10-page paper. So I'll do my civic duty to the world of knowledge, and I'll do that. Oops, I didn't show let me show that. Yeah, it was 318 pages. They gave it to me on a Thursday and they wanted it by Saturday, and it's like, really? And they said, yeah, so I did. And they had a bunch of these plots in there, and one of my responses was, take all the verbiage out. I don't care about it. I mean, have it as a file of reference. It was the plots that mattered, the diagnostic plots. Here's the papers that they included for the diagnosis, BNP and the diagnosis of heart failure in emergency care settings. Pretty narrow. But you can see here's the sensitivity of all these studies, and here's the summary down here. That's good. I mean, that summarizes the information, easy to see, clear, well, much more clear than hundreds of pages of text. You can see the specificity, not as much agreement on that. And you can actually click on, I told them, I said, you need to make it drillable on each study so I can figure out why this one differs. Anyway, we had a checklist in Colorado for evidence-based reviews of medical literature that we put together. And what we're working on now, and this is something that we could use definitely help with, is being able to put that into an XML format so that it can be used by anybody. And it can be put into a database easily, or it can be put into JSON if you want to use it in big data. We have a guy named, we have a whole group at University of Mississippi that, Arthur Guyton was the author of the book on physiology. And I didn't know, sometimes you don't know what you don't know about your own institution. So I remember one day I was sitting there talking about how much I love data, and this guy chimes in. I'm like, really? That's pretty weird. And anyway, they build models. And they built this model of cardiac function, 5,400 publications, quantitative information out of it. They have a model that uses like 7,000 variables. I'm not even that patient. And you can see here, the solid line is what the model predicts. The dotted lines are not that far off. So they're able to predict actual patient bleeding behavior. I'm not as interested in, traumatic hemorrhage in the ED, so it's not an area of interest for me, but I am interested in the way that their data looks. I'm like, wow. In other words, I'm interested in the process for them. And I'm also nice to them. I don't tell them that I'm not interested in bleeding. Although I sort of am, but not Anyway, you know what I mean. Hospital readmissions. They've had several hospitals that have focused on, this is predictive modeling. So we're moving up higher in the analytic hierarchy. And recently there was a presentation by folks from Allina Hospital, 15% reduction in readmissions, 20% reduction here at Parkland, and they had government funding to do it. You say, well, and here's the tragedy, and this is going to change. The comment that you will hear is, well, yeah, but what about the reimbursement, the revenue you're going to miss out on? Because some of those they'll pay for, especially if they're non-Medicare. That's going to change. And my comment is always, why aren't you working on the problem now before they don't pay you for it? Incidentally, some of the hospital stuff that I showed you, on the outpatient side, I didn't show you the revenue figures, which our hospital, we can also get. Net revenue, not charges, what you actually get in the door. We're making money on some of those tests. So the response would be, for at least the outpatient ones, well, even if they're unnecessary, Brimhall, just keep doing them. I mean, what's wrong with you? Just who cares? Well, from an intellectual point of view, you're going, if you're doing unnecessary work, why? I mean, what's the point? The second thing is, if you don't think the government, in fact, I know the government is onto this because I gave a presentation this summer and a guy from CMS came and talked to me. Yeah, they know. So they're going to be on top of it, especially given the current climate in DC looking at this. But the second thing is that private payers are aware of it too. I mean, and so when you don't get paid for it, wouldn't you rather be ready for it? Say, look, and when that time comes, your demand as a laboratorian with analytic skills would be even higher. Because the paradox is, the worse things get in healthcare, the higher the demand for those kind of people. This is just a weird story. This is kind of just more for fun. What's the risk of recurrence for this, for ductal carcinoma of the breast? And they have this company, this should look familiar. Genomic Health built a model, predictive model. And I'm going through some of the different parts of the model. And that's really cool. But then, and I don't think any of these is patented genes. So it's just basically the model and maybe the way they put the model together, I don't know. So if you look at, this is the part that's interesting to me. Yeah, their growth in revenues over the past, since 2003, 131% compound annual growth rate. Now, are they making that in profit? No, because they're spending a lot of it on research and development for the next bigger and better thing. Am I a big fan of Genomic Health? Not necessarily. I mean, they inquired about, I was called by them, a few months ago. I don't really have any interest in moving to California. But what it does illustrate is that somebody is paying for this stuff. It has some value to somebody. Maybe it's too much, but nonetheless, it was a predictive model. That's analytics. That's level, you're getting up to levels 9 and 10. And I'm showing you those just to show you that that level of analytics does exist. And additional outreach business. When I was in New Mexico, we picked up clients and we were offering them not level 1 analytics, we're offering them level 1/2 analytics, which was, we'll provide you reports of utilization for your providers. I mean, pretty stupid stuff. So we would get, and we would get in the car, and I went out with the salespeople. I think that's incredibly important to do if you have outreach. You got to get in the car and drive out and meet people, because that's where everything happens. Then you find out what they're interested in, what their pain points are, and that's how you pick up business. You pick up these little hospitals, and each of these hospitals was profitable, and the net additional revenue per year is a little over $500,000 for these, but it's a few trips, a few conversations with hospital CEOs of these small hospitals. Would you be interested in this? Would it help you? Absolutely, because I can't get a good handle on what's going on in my hospitals. I think you'll find, if you talk to hospital administrators, that most hospitals are like bumblebees. There's no reason they should fly, but they do. We don't know why. And from an engineering point of view, it should not work. And they have a hard, the finance people are great people because they kind of know that. And if you reach out and talk to these finance people, don't be offensive to them, but realize that we're not like other industries. We can't tell what the crap's going on half the time, because we haven't grown up in an environment where we've had to until now. Now the cost accounting becomes very important because we have to know where the money is going. What are we getting? Is it working? What's unnecessary? What's not? What are the patient outcomes? And, you know, not just process outcomes, but what real outcomes. So, and the most important thing in the lab is data. We were willing to do this because they were willing to give us their data. Remember what I showed you about Google? I believe it. We don't need any extra money for it, because that was a common, well, if you're going to go do this, Brimhall, this service for these hospitals, you need to charge for it. I just want their data. I don't care about the money. The money's not going to make up for what I can do with the data, because then you can build a benchmarking service. Mike knows what you could do with that. You could build all kinds of side things with that. So I don't need the money. So analytics, expand the scope of collegial work. This is what I would advise us as a profession to do. Professional. I spend many afternoons nowadays over in finance. But you're a doctor. Yeah, but I want to make sure it's done right for two reasons. One is when they're threatening to cut my microbiology staff from 12 to 1, because a lot of administrators, they look at numbers, there's no data provenance. It's like, well, it says you should have 1. Sorry. Like, really? Well, that's great. You know, bad data is the problem. So then you have to prove it. You can either accept what they say, or you can prove it, or you can pound your fist and say, I'm a doctor, I'm better than this, I don't need to put up with this, or whatever you want to do. The most effective way, though, is to go find the data. And then you build trust, strengthen analytical skills. We need to do that in our training. And I've heard that you guys might be starting that. I think you'd be the first, and I think you're positioned to do it. And then keep it fun. And that's it. We have 5 minutes? We have 5 minutes if you have any questions. Yeah.
You know, this was an excellent talk. The one thing that I wrestle with in trying to do this work is how granular does the model need to be, does the cost structure need to be in order to use it for improvement, in order to use it to improve patient outcomes, in order to lean out your system?
I love that question, because, you know, for me it's never granular enough. You know that. But the problem is we live in reality, and in reality there's always some granularity missing. Part of the reason in that model that I showed you for putting let me see if I can find it, putting some of our data into, I might not get there fast enough. Part of the reason for putting it into big data is big data, right now the way I look at it is, it's like a garbage basket where you put all kinds of weird data. You know, your plumbing flow rates, you say, well, why? Because you never know when that might be important. Legionella outbreak, maybe that could be, now we can pull it out of the big data and use it. But for a lot of the stuff, it's not feasible to do that. So we had two different systems, the big data system and the relational database. If it's not granular enough, you use your subject matter expertise and you estimate. So like I said, with some of those financial figures from the hospitals and the payers, I'm not claiming because of the way we did there might be the 32-year-old with neuroblastoma. Okay, fine. So what I'm asking, are you going to say that the $32 million is meaningless because you're off by 100? Really? I mean, is that, you know, because in the world of business, it's not quite the same as, well, actually it is. In laboratory medicine, you know, a nanogram is not always exactly a nanogram the way we measure it. We have variability around our tests, so there's variability sometimes around the numbers we get. But sometimes you have to settle for what granularity you get. And you can sometimes find other data that will fill in the gap. Like we were looking at socioeconomic status and laboratory testing. Well, there's no field where they say, you know, are you third estate, second estate, first estate, are you king, what are you? They don't ask that. So how do you get at that? Well, there's zip code. So if you're creative and you kind of know the data structure, you say, zip code. Well, I know that incidentally payer was in there, so you can go to the payer and say, well, are you being paid for by Medicaid? You're probably poor. But zip code, well, you can tie the zip code to US Census data. What was the median household income in that zip code? What was the percentage of people living in that zip code that had college educations or higher? So you can have surrogate ways of looking at that same thing. And if you make a case well enough, then you could say, you know, maybe hospitals need to have some, I don't know if I'd like that though, tying into your income. I don't know, that's getting too NSA for me. But yeah, I know what you mean. Did that sort of answer what you were getting at?